I'm Matt Jones. I'm a consultant anaesthetist in East Kent hospitals, right down the bottom right-hand corner of the country. I've been a consultant for about 20 years now, and my specialist subject is vascular access, which sounds very boring, but it is something that I've spent my life, dedicated my life to. I leave all the exciting stuff like difficult airways to all my colleagues, but yeah, so as Steve said, I'm a bit of an expert in this field. I did a presentation at the association, which is what Steve asked me to sort of bring to you today. So what I'm going to talk about for the next 40 minutes or so is stuff that might have passed you by in terms of issues around central venous access, placing central lines. Basically, we all sort of learn how to do central lines as a trainee, and then we move on. I'm really a sad person, and have made this area of practice my specialist subject. So I do read journals and articles and publish stuff around this, which doesn't normally make it into the mainstream journals, which is probably why some of this sort of best practice stuff hasn't been adopted widely within the UK, which is why I'm going to share it with you today. So what we're going to talk about, I'm going to briefly talk about enslaved line insertion. We're going to talk about line length, and we're going to talk about an interesting concept that you might find interesting related to tip position and the use of chest X-rays. We're going to talk a little bit about the modern, issues around securement and fixation, and the drive for zero infections, which is a bit of a hot topic at the moment in this world. So we'll just quickly go through that. So safe central line insertion, what does good look like? Obviously, do most good and least harm to the patient. The problem with the central line is it's an iatrogenic procedure. The patient doesn't come into hospital to have a central line put in as a first choice thing. It's something they have as a result of being ill, usually, or having major surgery. So it's sort of behoving upon us to try and do the best we can to not actually increase harm to the patient. And the key thing, as I teach my trainees, is that we need the correct choice of line. And I'm going to talk a bit long and hard about length today. It's not so much about how big it is, what gauge it is, how many lumens it's got. These are all interesting topics, but the key one is length. It needs to be in the correct vein, in the correct position. Now, when I say the correct position, it needs to be in the correct position at the top and the bottom, and I'll talk extensively about that. It needs to be placed correctly without any complications, secured correctly so it doesn't fall out, cared for correctly so it doesn't have any complications, and removed appropriately. That's a sort of ideal gold standard that we are aiming for. So first question, is a line really indicated? Central lines are potentially quite iatrogenically dangerous. They are fraught with complications, as I'm sure you all know. And I don't know if you do or not have a skills or a team or people who can place PICC lines, peripherally inserted central catheters, but certainly nationally and globally, there's a drive towards using PICC lines earlier in ICU, particularly rather than CVCs in the neck, mainly because of the overall lower complication rates. So first of all, is a line actually indicated? We tend to just go, central line, art line, and crack on with these cases because that's just sort of the default position. But actually, it might be worth really questioning whether a central line is really indicated. A lot of drugs that we give because of central, they have to be given centrally, can actually be given peripherally if they're diluted properly, for example. Preparation, consent, kit setup, including choosing the right line length before you start. So this is probably something you've not even thought about. I don't know what your standard lines are, whether you have a selection of 12, 16, 20 and 24 centimetre lines, and take time to make sure you get the right length line before you start your procedure. The checklists, again, the sort of NATSIPs, the National Safety Standards, I'm assuming you've got something like that, and making sure that your environment is optimised to minimise the chance of problems and complications. Optimize your environment. So it's fairly straightforward. Again, you'd be amazed at how many people make an absolute dog's breakfast of putting a central line in, but getting everything set up optimally absolutely increases your chances of first-time success, and this has been proven with papers factors and so on. So, you know, it's position the patient optimally, position the ultrasound optimally, lay your trolley up. So when I do mine, this is what my trolley looks like when I'm laid up. Taking a bit of time to lay everything up as you use it sequentially will help you greatly in success, in first time success. Lighting, distractions, noise, positioning your assistant, and so on and so forth. Lots of studies showing obviously human factors being interrupted on ITU when we've had a number of, even locally, a number of never events in relation to central venous access. And one of the biggest problems we face, one of the biggest causes is distraction. On ITU, it's extremely busy, noisy, the alarms are going off behind your head, and it's very, very easy to get distracted during a highly complex task. And it's been well proven both in simulation centres and in real life that trainees' chances of success and go down, and the chances of complications go up the more they are distracted. So it's sometimes worth having someone else on ITU, particularly having another person look after the patient while the operator does the central line. I know often that's not the case, not possible with the numbers of staff you've got, but if it is possible, you need to take the operator out completely from the care of that patient, so they're not turning around going, or give another bolus of metaraminol because the blood pressure's dropping, or the nurse is shouting and the SATs are dropping while they're trying to do the central line. These are just examples of lot of CVC insertions. I'm assuming you've got something similar up and running in your hospital. This is the one we use in my hospital at the moment. We've just updated this following a major never event, which I may talk to you about later. Safe insertion, obviously you should use ultrasound. There is no place, and it is indefensible now, to not be using ultrasound to place central venous catheters. It's basically just mandatory, and people actually need to when they learn how to do ultrasound, it's quite difficult because a lot of, even in my hospital, a lot of my older colleagues aren't experts in using ultrasound, and then they're the ones who are teaching the new trainees, and they actually don't teach them properly or teach them quite bad practice when it comes to ultrasound. I'll talk a bit about that in a moment. And then obviously maximum barrier precautions, I'm sure you know about. But when it comes to ultrasound, so first thing I want to talk about is this concept, which is just a little aid memoir, which I try and instill in the trainees. It's called Receiver, Rapid Central Vein Assessment. This is the first use of your ultrasound. So before you even start putting the ultrasound in, you go through this 6-point check, 2 Ds, 4 Cs. You want to look at the diameter, position, and patency of the vein. You want to look at the depth of the vein. So you make a depth assessment with the ultrasound. When you see a trainee pushing in the introducer needle to the hub, when they know that the vein is only 1 centimetre below the skin, you know you're only going to run into problems. Does the vein collapse during breathing? Is it compressible? Make sure it's absolutely clear which vessel is which. And in fact, I've done so many of these over the years. I've seen some really amazing anatomy where the subclavian artery is arching right up into the neck and overlaying the internal jugular, and it makes it very, very easy to get into some really sticky water. You can map out all the other structures, so the other dangerous structures nearby. And this is what I'm also going to talk about later on, is about securement and fixation. So what you want to do when you're scanning the vein is actually have a look at the convenience of the exit site. So when you're planning where the vein is in the neck, I'm just talking about the neck as an example, where you can see a nice vein, maybe you think actually that's okay, but the exit site is actually rather inconvenient for the patient, and I might be able to go a bit lower, and I'll talk about the benefits of going lower in the neck. It might be a slightly more difficult venous access, but if you're skilled enough, then that will infinitely benefit the patient going forward after insertion. Again, hopefully I'm preaching the converted here. These are why ultrasound is important. Optimizing your environment, orientation, image quality, anatomy, using the color flow Doppler, being an expert probe manipulation, and tracking the needle at all times, and using in plane and out of plane views, using small hockey stick probes rather than the larger probes if you want to. Again, it's up to you, but it's really, really important that people are adept at using ultrasound, because this is what we use it for. We use it for vein assessment, as I've said before, vein choice. You can use the Doppler to check the flow. You can use it to make sure that you're doing a venipuncture, not an artipuncture. You can check the direction during cannulation if you're able to track the needle tip at all times. Most importantly, once you put the guide wire in, we now teach, and it's mandatory that you use the ultrasound to track the guide wire to make sure it's going in the correct direction. Either isn't that it's not in the vein, or more importantly and more dangerously, that it's not in the artery or in another vessel. You can use it to rule out a pneumothorax after you finish after they finish the case, and you can use it to verify the tip position using a simple echo and air bubble technique. But I'm not going to talk about that today. But if you're interested, that's becoming increasingly popular, and it's very, very sensitive and very accurate. But the ruling out the pneumothorax I'll talk about a bit later on as well. So, first thing that you may or may not have thought about since you were, taught to do central lines is about line length. It has become increasingly obvious, and the literature that I read, as I said, there's actually a Journal of Vascular Access, an American journal, which is the kind of Bible for us, which is where we publish all our work. It has become increasingly important that the length of the line, that's shown about how important the length of the line is. And that is because of the tip position. Now, the tip of a central line needs to be sitting in. There's two factors that absolutely improve the quality and safety of a central line. One is that the tip is at the cavoatrial junction or just inside the right atrium, and it is lying parallel to the vein wall. If it is not meeting those two criteria, then you are going to cause your patient harm. Okay, and this is proven beyond doubt, and I'll show you some slides that relate to that at the moment. So this is about the worst chest X-ray I've ever seen. This patient, we are going to cause this patient, absolutely without a shadow of doubt, huge iatrogenic harm, because both of these lines, this patient happens to have a vas cath and a PIC in, I believe. But the point I'm making is that both of these lines are at 90 degrees to the vein wall. So these tips here are going to be eroding, this causing a massive inflammatory response on the intima of this vein wall here, which is very, very bad. Okay, so this is not what we want to see. All right, and I'll explain why that's important. Again, it's very important that the tip of the CVC is at the cavoatrial junction and lying parallel to the vein wall. Once you start to understand this and you look at what lines we use, the central lines that most hospitals have are 16 centimeters long. When you do the studies that should look, if you give an average anaesthetist a 16 centimeter line, say put it in as a central line in the neck, we're talking about the right internal jugular here, it doesn't reach the cavoatrial junction. This is a revelation, okay? The studies that have been done normally show that you need a 20 centimeter line if you're doing a right internal jugular, or even a 24 centimeter line if you're going from the left. The 16 centimeters usually not long enough. Now, what I say usually, if you've got a very small patient, about 5'5.5" or less, and you're going very, very low in the right internal jugular, just below the clavicle, just above the clavicle, you will be able to get to the cavoatrial junction with a 16 centimeter line. But it is an exception, not the rule. As I said, there's an increasing and growing body of evidence that shows a significant patient harm occurs when the tip is not ideally positioned. So at the cavoatrial junction or just in the right atrium and parallel to the wall. It is worth remembering that the tip will move up and down with respiration and when standing and supine. So it's a bit of a, it's a bit of a variable beast anyway. But the more proximal you have it, or more an angle to the wall, the more chances you are of causing the patient harm. What do I mean by harm? Well, what happens is this, is a cascade. You cause increased endothelial damage to the intima of the vein wall. This has been shown to cause an increased risk of non-clinical, non-observable thrombosis on the vein wall. It triggers off an inflammatory response, okay? Particularly if you're doing exactly what the central line is designed for and giving very toxic drugs down it. So not only are you causing a mechanical endothelial damage, but a chemical endothelial damage at the same time. This inflammatory response kicks off, causes a thrombosis and an inflammatory response, and it has been clearly shown that this leads to an increase in line sepsis, which leads to an increase in body sepsis, blockage, line failure, and an increase in mortality. So basically what we're saying is that if you leave your line too short or an angle, you are going to increase mortality. And that's quite a revelation. All right. It is, again, there are many, many papers out there. I'm not going to just show you clips of papers and papers. You're welcome to review it yourself. But this particular paper here actually said, clearly the internal catheter tip should be positioned at the cavo-atrial junction or within the right atrium. People often ask me, well, what about, isn't it dangerous going a bit long? Are we not going into sort of tiger territory? Well, no, because the incidence of morbidity and mortality rises exponentially the further away you get from the cavo-atrial junction north, approximately. There are almost no studies showing patient harm caused by a line being too long, particularly just a standard central line. Okay, the number of case reports that have been published are infinitesimally small. So I do not, it is not, there's no evidence based, no strong, hard evidence based to show that having a line too long causes harm, but there definitely is if a line is too short. Okay. So that I'm just gone on about, we're going to now talk about insertion chest x-ray. So how do we know where the cavo-atrial junction is? The problem is, are all staff, trainees, knowledgeable? Does anybody know where the cavo-atrial junction is on a chest x-ray? There's a huge amount of variability amongst clinical staff. We don't actually know where the tip is anyway. People say, oh, we use the carina as a landmark. We can use the vertebral bodies as a landmark. And there are papers out there that I've just picked this one, which is quite recent, and I think this is about right. And it basically says if you are going to use a chest x-ray, then your tip needs to be about 2.5 to 3 vertebral bodies below the carina, and you're approximately going to be at around the cavo-atrial junction. Okay. So, however, I will now go on and talk to you about whether actually a chest x-ray is the right thing to do for tip positioning and whether it's actually necessary. Chest x-rays are expensive to organise. If you take all costs, they're time consuming. They involve irradiating the patient. They are very inaccurate when it comes to tip position for a number of reasons, which I'll talk about. And they are very bad at ruling out a pneumothorax, which is another argument that I get thrown at. So in my world, I try very hard to move away from using chest x-rays and using a different technique, which I'm going to talk to you. The other point is I did a whole survey of about 400 chest post-line insertion chest x-rays on ITU, and I found over 30% of them on ITU were absolutely useless for this purpose. I'll just give you and we've all been there. We all know this. This is what a quick mobile chest x-ray in a very sick patient looks like, on ITU. Is the line in the right position? How on earth is anyone going to be able to accurately predict or point out that that tip is at the cavo-atrial junction using this type of imaging, which is fairly normal? Certainly is on my ITU, up over 30%. So a third of these are a complete waste of time. All you're doing is just irradiating the patient and spending money completely unnecessarily. So I banged on about this. The tip needs to be at the cavo-atrial transition or in the upper part of the right atrium. Okay. What does that look like on a chest x-ray? Like that. Okay. So just digest this. This tip is just above the right atrium. On a fairly good chest x-ray, that's about 2.5, 3 vertebral bodies below the carina. I will say to you, if you took a poll of all of you on this group, how many of you think that line is too long or too short or in the right place? I would probably hazard a guess that the majority of you will say that that chest x-ray suggests that line is too long. It is not. Okay, that is proven with an echo. That tip is at the cavo-atrial junction. Echocardiography, particularly transesophageal echocardiography, is the gold standard method by which all of these studies are used to confirm tip position, where you can actually physically see with great clarity where the tip is in relation to the right atrium and the cavo-atrial junction. But that tip there is at the cavo. That is not even in the right atrium. That is at the cavo-atrial junction. Okay, so that's what a chest X-ray should look like post insertion if you are going to use a chest X-ray. That's what we want to see. Okay, it's about 3.5 to 4 centimeters in measurement terms. That's the same chest X-ray below the carina. Okay, and even radiologists don't know this. So the number of radiologists, so there's a study, really good study done where they did a echo of 100 central lines placed correctly at the cavo-atrial junction, did a chest X-ray and sent it to the radiologists of their opinion of the tip position. 3/4 of them came back reported as being too long. Okay, so even the radiologists haven't got a clue, if I'm brutally honest with you. The other reason people say we should do a chest X-ray afterwards is to rule out a pneumothorax. Firstly, if you're competent using ultrasound, you shouldn't be causing a pneumothorax in the first place. There's absolutely no way, if you know where your needle tip is at all times, but things can happen. We all live in the real world. But the point is that a post-insertion chest X-ray is usually absolutely useless, okay? Because your initial chest X-ray won't show anything. It's only when the patient collapses later, 4 hours later, this is a good example, and it's been well shown that an initial chest X-ray to rule out a pneumothorax is completely useless. The way to do that is to put your ultrasound probe on the chest at the most anterior section of the chest and just check that there's no air in the chest. Infinitely more sensitive and real time and much less hassle. So is there a better way of getting your tip in the right position? Well, this is a new concept for some of you, possibly. I don't know how many of you may know this, but I'm going to talk a little bit about this. This is what I do, and this is what we do in my trust. And in fact, this is what they do across most of Europe, actually. And it just seems to have passed us by in the UK, particularly in our intensive care units. And this is using an ECG system to verify your tip position. It has been shown using the TOE comparative studies to be one of the most accurate ways of getting your tip in the correct position. It costs almost nothing. It costs about £3 with an additional piece of equipment. It is extremely safe. It doesn't pose any harm to the patient. It's very easy to use, particularly for an anaesthetist who can read an ECG. It's very quick and it does not require a chest X-ray. If I was to say to you, I've got a new technique that is cheaper, quicker, safer, and more accurate and better than your current practice, why wouldn't you want to adopt it? And this is a message I've been trying to get across, to people in the UK. So I'll just very quickly explain, because you're probably scratching your head thinking, what on earth is he talking about? Basically, what you do is you attach, you take the red lead off the patient's chest and you clip it to a connector that's attached to the distal lumen of your central line. I'll show you some pictures. Then what you're doing is basically your lead 2 on your ECG on the monitor behind your head on ITU or in anaesthesia and theatres will now be showing an ECG trace that is being read from the tip of your central line. Then as you pass your central line down the superior vena cava towards the right atrium, the P-wave morphology just changes in a very, very characteristic and very obvious manner that allows you to very accurately predict and know where the tip of your line is. And basically what happens is it affects the P-wave. Obviously, as you're getting near to the atria, it's the P-wave morphology that changes, okay? So what happens is, as you get closer to the right atrium, the P-wave gets bigger. And I'll show you what that looks like, okay? So here's a normal ECG. I've connected the line to the lead 2 of the ECG. As I'm coming down the superior vena cava, as I get nearer to the right atrium, what you see is the P-wave amplitude getting much, much bigger. So here, what you've got is what we call a maximal P, the biggest P-wave. It means you're just above the right atrium at the cavo-atrial junction. If you enter the right atrium, the P-wave starts to become biphasic like this, okay? So when you're in the middle of the right atrium, it's obviously biphasic. And if you go past the right atrium, then it goes negative. So it's very, very characteristic. Obviously, these ones, the line is probably in a bit far. What we're aiming for is this maximum P, with the P wave is huge like this, means that the tip is at the cavo-atrial junction. Okay, there's another exactly the same that just shows that your maximum P cavo-atrial junction. What do you use to connect it together? This tiny little packet. I've got one here. That's what it looks like. It's just a piece of plastic, bit of wire like this. It's just a little piece of extra kit. Costs about £4, infinitesimally cheaper than an X-ray. And basically what it is you could just, I'll show you on the next slide actually. You just connect it to the brown lumen. Once you put the line in, you connect it to, on this particular model, the brown lumen is the distal tip lumen. You flush it with a column of saline, and the column of saline now transmits the electrical impulse up the line, up the red lead, which you've connected to, or you've got your assistant to connect to, the lead on the patient from the patient's monitor. Okay, and that's it. And then you flush saline down the line, and as you're flushing this, you create this column of saline, and it produces a very characteristic trace on the ECG. So this is one I've done using a slightly different connector, but it's the same principle. This is what you're looking for. So this is your baseline ECG, and this is your maximum P wave. Okay. This is me in real life. This is my arm, just showing a trainee taking a photo when I'm doing it. This is a real world ECG on ITU. Obviously, you can see the art line trace here. And here you can see the maximum P. You'll see a tiny negative deflection just here. And this is because the patient's breathing in and out. So the tip just moves. It's so accurate. You can actually see where the tip is in relation to the breathing of the patient. So here you don't have a tiny negative deflection because the patient's just breathing in, and so the myocardium's dropped slightly, pericardium's dropped. But that's what a maximum P looks like. So that big spike there is actually a P wave, not a QRS. That's the QRS there. Sorry, that's the QRS there. And that's the P wave, maximum P. I'm very happy that line is in the right place. I can also record it and just print it off on my ITU to put in the notes as a medical legal record of where my my line is. Now, you might be saying to me, oh, why aren't we doing this? This has all been proven and established and is now routine practice in most of Europe. Okay, we just somehow in the UK seem to have passed it by. Just to reiterate that, in Europe, I picked up this central line from a German colleague. This is a central line who's the man? This is a Vigon one, but Arrow do exactly the same, to the point where they actually put the ECG lead in the central line pack because it's used every time the patient has a central line. Okay, so it's not rocket, it's not pie in the sky stuff. This isn't new. This is well established. We just haven't really picked it up in the UK. This connector, this line I'm talking about, actually in the packet as an essential piece of equipment for actually putting the central line in. So that's ECG tip location. Very simple, very quick. It requires an extra 30 seconds just to connect the connector, flush it with saline, give it to your assistant to connect to the red lead. And then as you push the line in and out a little bit till you get maximum P, and then you know exactly where you are. You don't need a chest X-ray post-op, because if you get that maximum P, you can only be in the right place. All right. Just going to quickly finish talking about securement and fixation. Really need to move away from suturing. Suturing increasingly shown to be very, very bad for the patient. It increases infection rate. It's very uncomfortable for the patient. There's a whole half. There's potential sharps injuries to the trainee who's trying to suture for the first time. So really, we need to be moving away from suturing onto sutureless fixation devices. Okay. So what we've adopted in our trust, and a lot of hospitals have taken this on, is to use mainly as the mainstay instead of the suture is a thing called a Secura-Cath, plus some other kind of fixation device to help secure the line. And I'm going to talk a little bit about skin glue, which you possibly aren't using, but is a massively popular and very, very well researched and shown to be an excellent addendum to our our technique. So what do we mean when I'm talking about securement and fixation? So low internal jugular approach. So what I say to the trainees is go as low as you feel safe to. Obviously, the lower you go, the slightly closer you are to structures under the clavicle, but it's fine. So whatever you feel comfortable with, or wherever that the vein is accessible. Basically, as low as you feel comfortable going in the internal jugular is what I recommend. Do not cut the skin, okay? Cutting the skin causes bleeding and increases infection. You do not need to cut the skin. You can dilate it with the dilator, like you would do a perk trachea. You just dilate the skin. Then when you put the central line in, the skin, the elastic tissues will close round the line, and it's been shown to significantly reduce the risk of a central line, extrinsic central line infection, okay? So you don't need to cut the skin. You do not need to suture it. If you suture it, you're going to make more holes in the patient. Every time you make a hole, you increase the risk of infection, and you also increase the risk of bleeding. Now, why is bleeding bad? We've all seen that when you've made a nice cut with a scalpel and you've sutured it a few times, then you put the dressing on, a little collection of blood appears underneath the dressing, okay? Once that blood is there, that is a perfect medium for infection, okay? So we want to minimize or eliminate bleeding. Okay, use a sutureless fixation device instead. Now, if you do nothing else, okay, and you take away no other message, I implore you to consider the concept of this, which is rather than take the line up the neck, lay it down on the shoulder. Okay, I'll show you some pictures of what I mean by that. Use a chlorhexidine-based product around it, so a biopatch or CHG dressing, and use some skin glue, which I've talked about already. Why do we use skin glue? It reduces strokes, eliminates bleeding, which reduces the risk of infection, which reduces morbidity and mortality in the patient. It's a no-brainer. It costs a couple of quid. You just use any old skin glue that they have in theatres. It provides better securement, so less chance of dislodgement. It is a profoundly antibacterial barrier, okay, which reduces the risk of infection, and it prevents pistoning. I'm not going to talk about pistoning. I don't think I've got time. Basically, when a line moves in and out through the skin, it entrains skin flora and increases the risk of extrinsic central line infection. So this is rubbish. This is what we don't want to see. This is what it used to look like, okay, when we try and secure something up the neck, particularly in a man. As soon as they grow a few days of beard hair growth, the whole thing just falls off and it looks like an absolute dog's breakfast, okay? This is not what we want to see, all right? Very bad, okay? What we want to see is this, okay? So this picture here is a central line, a standard central line that we would use in our ITU. This is a right internal jugular line, okay? Now, some of you may historically remember papers that were published that show that subclavian lines have a lower infection rate than internal jugular lines. I will take to you that has been proven. It's got nothing to do with which vein you access. It's everything to do with how you position the line. So if you position a line like this, you have the same infection rates as a subclavian line, even though you've gone into the right internal jugular. Okay. So just go into the right internal jugular and lay it down. Even if you're slightly higher up the neck, you can swan neck it down. It's really not a problem. But you do need a long enough line, which is why we're talking about line length as well, because it's really important that you have enough line to get this line up down to the caveatrial junction and have enough to lay it down on the shoulder. So don't be afraid to go for a longer line and leave a bit more on the outside. Okay, so that's what we want to see. There's another real patient. That's a right internal jugular line laid down on the shoulder. I do live in the real world. The nurses have allowed blood to clot in this one, so this line is now defunct, but it's clean, it's dry, it's, you know, it's nicely positioned, it's really comfortable for the patient, has a lower infection rate, lower dislodgement rate. Just to go through that particular line in a bit more detail, instead of suturing it, I use a particular product called a Securacath. I'll talk about that. It's a very, very good product, actually, and I would implore you to consider using it. It's just a simple little packet like that. If you can see me in the pawn, it comes in a little packet, little orange thing like that. And basically, this we use instead of a suture. So we have the Securacath there, holding the line in the patient. I've got a grip lock here, which is just like a sticky fixation device. You've got stat locks and other ones, which just secures the hubs nice and neatly on the patient's shoulder. There's a biopatch in there. Now, the reason why these lines like this, or subclavian lines that are laid on the shoulder, have better survival rates and lower complication rates is because they're not affected by the movement of the head, or if the patient dribbles or drools and any goo comes out of their mouth, it doesn't go down onto the dressing and into the central line. Yeah, just lay it down on the shoulder. What more can I say? That's a Securacath. Why do we use it? It's very easy to use. It's as secure as a suture. Infection wise, when you change the dressing, you can actually lift the line up so that you can clean all the way around it, okay, around here. And that's why you get lower infection. Once you suture a line down, this little bit underneath here where you can't get to is the area where infection develops. But with a Securicath, when you change the dressing, you can lift it up, and you can 360-degree clean it round while it's secured. So it's much less messy. You do need enough length to be able to reach the caveatrial junction and secure it on the shoulder, which is why we now routinely use a 20-centimetre line and have 24 centimetres. So that's a line I put in a patient recently that you saw in the picture. There's the 20-centimetre line marking just there. So this line is in about 17 centimetres. So if I had a 16-centimetre line, I wouldn't even have reached the caveatrial junction, let alone have enough line on the outside to lay it on the shoulder. Okay. You can also see I haven't cut the skin and I haven't sutured it, so there's no bleeding. It's very tight and neat around the skin here, so it's a much lower risk of infection. Okay, so here you go. There's a guy who's had this central line's been in 2.5 weeks in my ITU. He's now recovering from a long period on ITU. And his central line has been laid out on the shoulder. He can turn his head from left to right very easily. He can shave. The nurses can look after him. When he's asleep, the pumps are over here on the side of the bed. So the central line is going in the direction of the pumps. So the nurses find it very comfortable. The patient finds it very comfortable. And you haven't had to change the central line. So a lot less hassle for everybody because they don't get infected quite so often. So it's a win-win-win, really. People often ask me, if you fold it down on the shoulder, does it kink? The answer is no. Certainly with the lines I use, which are, I think, fairly standard in the UK, we use an Arrow Teleflex line, the blue one. It's fairly kink resistant, and it will certainly cope with bending like this without, this is an X-ray of it, doesn't actually kink, okay? So take-home messages just to finish with. Move away from suturing if you can. Use a Securicath and a securement fixation device like a Securicath. Use skin glue. These are very easy little things that you can do to change your practice and make a huge difference to the patient. Even if you still have to suture it because you don't have a Securicath, still lay it down on the shoulder. Okay, glue it. Keep the suturing to a minimum if you have to, but I would really implore you to look at exploring the use of Securicath rather than suturing because you don't have any bleeding, and lay it down on the shoulder. Consider your tip position. All right, having it short is really bad. Okay, really very bad. And when I see an X-ray like I saw with that line at 90 degrees to the vein wall, I'm just thinking we're basically causing the demise of this patient by doing that. It's really that serious. Okay. More advanced, if you want to, just get hold of this little adapter. This particularly comes from Vigon. I can give you all the details. If you're interested in the ECG tip thing, I've got a very simple one-page aid memoir A4 sheet that gives you very specific instructions on how to do it. I've just introduced you to the concept, but as you know, relatively intelligent anaesthetist, it'll take you about 5 minutes to learn how to do it. And it is very, very accurate, very quick, and very simple. And more importantly, interestingly, if you do it pre-op, like for a big case in theatre, and you do it when you're doing your lines in the anaesthetic room just before a major case, you then already have really good assurance that your line is in a brilliantly good position without having to rely on an X-ray, which possibly is going to be done after the operation. So you get that confirmation straight away that your tip is in the right position, so you can use it with confidence perioperatively rather than waiting until the patient has a chest X-ray post-operatively. And be safe and aim for 0 complications. So all of this stuff is around trying to reduce the risk of dislodgement and infection, making a better quality for for the patient, lower complication rates, and so on. And in fact, there was a really good study I saw presented by a conglomerate of 4 ICUs in the Netherlands who have gone all out and actually adopted all of this best practice stuff to the nth degree, and they have gone 2.5 years now without having a single central line infection. They have never had to change a central line because it's infected. By using all of this evidence together, you know, all this best practice stuff put together, you can really, really make a difference. And that's been shown, as I said, by this study by these 4 units in the Netherlands. So there we are.